everybody. Thank you guys so much for being with us tonight. I hope that this is helpful to you. Appreciate you listening. This program has kind of been my passion project. I started the program when I got here 4 years ago, and I've been building, and we have a really great program going very strongly, and I'm happy to be able to talk to you guys about it tonight. So basically what we're going to be talking about is weight loss surgery, the answer for you. And that will cover a couple of topics. Just to first introduce you to myself and my team, I am Mary Hanisee, but I go by Katie. I am fellowship trained specifically to do this. This is what I spent my time doing after I finished residency, because I wanted to make sure that I was the expert, that I could do everything I needed to do for this. I finished that program and I came to set up shop here in Thomasville and started the program. Jennifer Langen is my PA. We work together nonstop, all day, all night. She's fantastic. She helps with everything from clinic to the operating room to after. This is Charlie Chasen. She is the backbone of our team. She is the main contact in the office. She keeps us straight, lets us know what we need to do and where we need to do it. She's just an amazing, talented, smart, and keeps me and Jennifer together. Jennifer also helps keep me together. And I think a very good point of contact for everyone. So today what we're going to be focusing on is, what is obesity? Why is it important to treat that obesity? And what are your next steps if you are interested in pursuing care with us? So first thing to talk about is, how do we measure obesity? I'll be the first one to tell you that a BMI is called a body mass index. It's not the best tool that there is in the world to measure this, but it's kind of the best tool that we have. What this looks at is, what is your height to weight ratio, basically. Now, some of this can be skewed. If someone's particularly muscular, then it's going to look like their BMI is bigger than they really are, and their health scores aren't the same. But that's something we keep in mind as physicians when we're looking at patients. So in general, what we consider obesity is a BMI over 30. That being said, you have to be a BMI over 35 with a comorbidity, or a BMI over 40 to qualify for surgery with most insurances. So considered to be, again, clinically severe morbid obesity when we have a BMI over 35 with one or more severe comorbid conditions, which we'll talk about what those are in just 1 second, or a BMI of over 40. Obesity is a very complicated thing, and I'll be the first one to tell you it's not always straightforward. Everybody has a different metabolism, and everybody is different with different foods. So we know that there's genetic components, we know that there's behavioral components, and we know that there are environmental components. What can you afford and what's available to you? We try to work within our program to affect the things we can. So obviously genetics, you get the cards you get, but with behavioral and environmental issues, we can help you to work to increase your options and increase your chances of being successful. It is a very common problem in the United States and the world, really. More than 65% of adults are overweight, obese in our country. It is more common in males than females, despite me having many more female patients. Males are just a little more reluctant to get help for it. 30% of boys and girls under 20 are obese or overweight. And so ideally, we can start to teach trends of what it looks like to feed yourself appropriately and take care of yourself appropriately earlier, so that we can make it so that patients don't struggle with this as a lifelong thing. Total medical costs for obesity in 2003 was $75 billion. And a part of that, that's why we've gotten support from insurance companies. We've gotten support from people in being able to work on getting people through. Trying to get everybody into the room right now. Got it. Okay. And then what we see is that there are 325 obesity-related deaths annually, which is significant. So just to kind of give you an idea of how things have changed, looking at 1987 data. What you'll see is the biggest proportion of patients are having little to no issues, with the very highest being 10 to 14%. We see in 1997, you're starting to see a lot of that darker blue and that yellow creep in. So now we're creeping to just under 25% in some parts, and then under 20% for most of the country. Now we're seeing that progress even more. So now we're seeing some of the red, the high, over 30%, and then the over orange is the under 30%, but still significantly higher. So we can see that this is an epidemic that's all across the nation that's worsening over time. Why do we care? It's not about a cosmetic thing for us. I would want my patients to be happy, confident, and feel comfortable in their own skin. But the reason that we treat it medically is because there can be comorbidities that are associated with that, increased cancer risk, of course, the life expectancy, and then the quality of life things we discussed before. So see, these are some of the illnesses that are associated with obesity. I want to separate, for me, obesity is not necessarily a negative thing by any means. It's when that obesity starts to affect your health in other ways that we really start to worry. Type 2 diabetes, hypertension, hyperlipidemia, respiratory disease, sleep apnea, depression, incontinence, cancers, reflux, heart disease, fatty liver disease, which is now the most common reason to need a liver transplant, are all things that we hope to improve with getting some weight off. There's also a cancer risk associated. It's becoming more and more evident that obesity and the increased hormones that we have secondary to adipose tissue contributes to worsening and cancer origination, especially with breast, colon and rectum, endometrial, esophageal, kidney, and pancreas. It also affects your life expectancy. It is the number 2 preventable problem after tobacco in order to increase your life expectancy. There's also the things that, when you're overweight that you have to worry about. Am I going to fit through the turnstiles? Am I going to be able to sit at the airplane and get my seatbelt? Am I going to be able to get to the top of these stairs? Those are things we don't want you to have to worry about. We want you to be able to just live your life in a way that's comfortable and happy. So why surgery? There are definitely options. There are definitely a lot of medical options that are out there, but surgery is the only thing that's been proven effective over long term for most patients with clinical severe obesity. I bring these institutions up because I want to point out that all of these institutions, they're all medical societies. None of these groups do surgery at all, but they have been able to identify as a third party who are unrelated that surgery is the best way to get weight off, keep it off, and decrease the chances of affecting your health with obesity. That includes the National Institute of Health, the American Medical Association, the National Institute of Diabetes and Digestive and Kidney Diseases, and the American Association of Family Practitioners. So what are the surgical options that we offer here? So I'm going to talk a little bit about first this procedure that we no longer offer, but it has been around the community. So I just want to make sure that people are aware of what it is. So are you a candidate for weight loss surgery? As we discussed, BMI over 35 with comorbidities that we discussed on that previous page, or over 40. Good surgical candidates. So have ability to get to our appointments, follow up with us, haven't had a million surgeries on their abdomen, and their heart and lungs can sustain surgery. Failed attempts at medical weight loss before, no current drug or alcohol problems, and no uncontrolled psychological conditions. I also, as I mentioned, we want you to be our patient forever. So once we see you once, we want to follow you forever. Make sure you're doing well, check all your electrolytes, make sure you're getting everything you need. So this is the adjustable gastric band. We do not currently offer this. I have taken a lot of these out. This is a laparoscopically done procedure. Mean excess weight loss of 1 year, about 42%, that then kind of rebounds to sometimes 30%. It does require an implanted medical device. With this, we take the lap band and we kind of put it, or other physicians put it close to the GE junction, or the gastroesophageal junction, which makes a small pouch which facilitates that early sense of satiety, or early sense of being full. We know this is not the best operation now after having some more data. So this is not something we continue to offer, though we do a lot of conversions from this to our other procedures. One of the 2 operations that we do offer is the sleeve gastrectomy. With this operation, we resect 80 to 85% of the stomach. This is a very safe operation. We do a lot of these. It is the most common operation done in the United States and the world for weight loss. Every patient gets a discussion on their comorbidities, their goals, and that's how we decide which surgeries for which patient. The sleeve is a good option for our patients who have a little bit smaller BMI and no reflux. Mean excess weight loss at 1 year is around 60%. There's no foreign bodies implanted, and again, very low risk. With the sleeve gastrectomy, we initially found that it was a good operation because it was part of a bigger operation, duodenal switch or BPD. It removes ghrelin, which makes you feel hungry. We make it basically so you can have 2 to 3 ounces at a time at first. This is irreversible because we do remove that section of stomach, but stomachs have a huge ability to stretch. And so going back to old lifestyle will lead to weight regain. What we know though is if you continue to follow up with us, you keep your support group meetings, we continue to keep 50% of excess body weight off at 10 and now 15 years. So that's really good information. I have a little video to share with you guys. If you're squeamish, you may not want to watch.
This educational video will explain the normal process of digestion, the sleeve gastrectomy procedure, and how weight loss will occur upon completion of the surgery. Currently, your stomach can hold about 40 ounces of food. Once in your stomach, the food combines with digestive juices containing acids and enzymes that help break it down into smaller particles. Once broken down, the small particles are slowly released into the first part of your small intestine, the duodenum, by a muscle called the pyloric valve. The pyloric valve is a ring of muscle between your stomach and your duodenum. Most of the nutrients from the broken down food are absorbed in the duodenum and the jejunum, which is the second part of the small intestine. There are 3 main steps in the sleeve gastrectomy. The first step is disconnecting the tissue between your stomach and your abdomen. The second step is dividing your stomach into 2 sections. The third step is removing the upper rounded left part of your stomach. In the first step, tissue between your stomach and your abdomen is disconnected. Your surgeon will separate the tissue that connects the left side of your stomach to your abdominal organs, such as the spleen and the colon. The second step is dividing your stomach into 2 sections. Your surgeon will divide your stomach using an endoscopic stapler. Your surgeon may also use traditional stitches or a combination of both staples and stitches to seal each section of your stomach. This seal is called the suture line. The third step in the sleeve gastrectomy is removing part of the stomach. Your surgeon will remove the left part of the stomach, which includes the fundus. The fundus is one of the areas of the stomach that produces the hormone that controls your appetite. The remaining portion of your stomach will be about the size and shape of a banana. Once you have healed from the surgery, weight loss will occur because of 2 reasons. First, your new stomach size will force you to decrease the amount of food you can comfortably eat. Secondly, the sleeve gastrectomy will cause your body to decrease or eliminate the release of a hormone that stimulates the appetite.
All right, just was checking the chat. You guys feel free to ask questions.
Hi, I'm Brittany Smith. I'm a dietitian with Ohio Health. Today I'm going to be talking to you about the full liquid diet. When you are discharged home from the hospital, you are going to be discharged home on a full liquid.
Sorry about that, guys. YouTube kept doing its own thing. Okay. Let me get this going back again. All right, so the next operation we have is a Roux-en-Y gastric bypass. This is one of my favorite operations to do. We usually do it using the robotic XI technology we have available here at Archbold. With this, we see a little bit higher weight loss. And so for me, my weight loss tends to range usually around 75% excess body weight loss at 1 year. Again, we have no implanted medical devices, and this is a very safe operation. We've been doing this operation longer than I've been alive, so we do know that it's safe, though we have tweaked it a little bit to make it an easier recovery. With this surgery, we make a small pouch at the beginning of the stomach that's approximately 1 to 2 ounces. And then we create a rerouting of the small intestine. So the first 100 centimeters of our small bowel is not getting any digestive juices. This makes it so we're both eating less and digesting less of the food. This is a particularly good operation for our patients with significant reflux or regurgitation and with diabetes. With this operation, we also tend to push it towards our patients who tend to have a BMI over 50 because the amount of weight loss is significant enough that it makes a big difference between the sleep. Here's our gastric bypass video.
Down food are absorbed in the duodenum and the jejunum, which is the second part of the small intestine. The steps in the Roux-en-Y gastric bypass involve dividing your stomach into 2 sections to create a smaller stomach pouch, dividing your jejunum into 2 sections, creating a Y connection between both parts of your jejunum, and creating a connection between your stomach pouch and jejunum. Your surgeon starts by using an endoscopic stapler and divides your current stomach about 1 to 2 inches below the area where your esophagus connects to your stomach. The smaller upper section of the stomach that is connected to the esophagus is your new stomach, also known as the gastric pouch. This gastric pouch will hold about 2 ounces of food. Next, your surgeon divides and seals your jejunum into 2 sections. Your surgeon will take the shorter part of your jejunum and reconnect it to the longer part of your jejunum at a point further below the point of division. Next, the remaining part of your jejunum is pulled up and attached to your gastric pouch. Food will now go from your new stomach pouch directly into your jejunum. Prior to surgery, food went from your stomach into your duodenum. Your duodenum and a small part of your jejunum are now bypassed and will not come into contact with any food. Because food bypasses the duodenum and part of the jejunum, fewer calories are absorbed.
Right, so that's a little bit of what goes into choosing what's the right procedure for each patient. We look at patient's age, the health risk, the comorbidities that I discussed, how much weight do they want to lose, what is the lifestyle that they want to have, what are their current eating behaviors, and what previous surgeries have they had. This is all a mutual decision between me and my patients. I give them all the options and I give them my recommendations, but unless it's unsafe, we go with whatever the patient requests. I like to discuss it with the patients, any family and friends, anybody, their support system that has questions, we encourage all of them to be a part of this procedure. The pre-op process usually involves a 3 to 6 month process, depending on your insurance. Not many of my patients have weight loss goals, but we do try to work on eating changes and exercise goals and try to get the changes that we're going to want for lifelong initiated. Work with a dietitian at every single visit. Every patient has a psych evaluation. Every patient has an EGD that wants to have a sleep or has any significant reflux. Sleep studies depending on the patient's symptoms, cardiology evaluation depending on the patient's symptoms and history, and all of our patients do a liver shrinking diet for 2 weeks before surgery just to make sure it can lift the liver enough to get to that stomach, and our patients do very well with that. Post-operatively, we like to resume normal activities at 3 weeks. We start to initiate soft food around 3 weeks, and we also get our patients back to work. We want to make sure patients are prepared. They can keep water and protein shakes and snacks and everything they need with them, and they have diet and exercise plans in place. We basically have them follow up with us and our dietitians forever, and we also have support groups that are online and hope to be in person again soon. Why we love this operation, why it's so fulfilling. Not only do patients enjoy looking at themselves in the mirror and feel good and feel confident, but also we have a huge amount of resolution of our comorbidities for a good number of our patients. You have a lot of options when it comes to bariatric surgery. There's several programs in the area. We are the only program with a fellowship trained bariatric surgeon. I think we have an excellent program, and we focus more on making sure we're listening to the patient and helping them to develop a good relationship with food so that you have good balance in your life and you're not always worried about what you're going to eat and what it's going to happen from there. We want to make sure that we work with you until this stuff just happens automatically. We have online and in-person support groups. We're based in Thomasville and surgeries performed here at Archbold, and we have local access and expert follow-up for everything you could need postoperatively. We do have some local people who can help with the medical weight loss aspect. We can also offer dietitian visits. We have separate support groups and medications, and those go through different offices, and we can refer you based on what you're interested in and where you live. So what's this next step? If you are interested in even just getting a little more information, you can go online to our request form from our website listed below. And my nurse Charlie will get back to you as soon as she gets a chance. You can also call our office to inquire. Again, Charlie will get in touch with you, or you can ask your primary physician for a referral. We always try to confirm your insurance coverage before we bring you in. We don't want to waste your time or have you have any unexpected charges. And so that sometimes is a little bit of delay, but very important to us. Does anybody have any questions? Just gonna move this over so I can look at the chat while we're together. I don't see any.
If you're not considered obese to the point where you need surgery, is there another recommendation for it to get a healthy weight loss?
Yeah, so I would recommend discussing with your primary options. There are a couple of medications that I have recommended in the past, one of which is called Adipex or phentermine. That one does tend to have a little more side effects, especially with patients with cardiac issues. Another medication that I have used with some success in the past, Contrave, which is CONTRAVE. It's a combination of two medications, and actually if you order them separately it's a little bit cheaper, but those are two good options. I think also following up with a dietitian and getting some education on what nutrition is always a good idea, and that's where referral your primary can place.
Okay. Thanks.
Yeah, of course. Any other questions I can answer? It can be about other things too. I'm also a general surgeon, so anything I can help with. Well, all right, guys, I would say if you think of anything, if you want any more information, or if you think of questions, please feel free to use either of the websites that are the email addresses that we provided for you. You can call my office at 229-226-8881, or again, reach out to that website. My nurse will get in touch with you and answer any questions that you have. I hope you guys all have a lovely evening.